Well, welcome to tonight's Healthcare for All program. I'm Ronnie Shore. I'm a retired pharmacist. Actually, I failed at retiring because I still work a few hours a week, focusing as a pharmacist, focusing on genetics. But it also feels like I have the opportunity of this actually feeling like a full time job, volunteering as president of Healthcare for All. Uh, Tonight, our program features a true healthcare champion, Kevin Wren, who's leading our state and who's actually an example for our whole country as a type 1 diabetic who is waking us up or alerting all of us to the need to improve access to insulin. So, a couple of notes about the fact that everyone is muted. So I have control of your life for the next hour. And we will ask you if you have questions or even, and especially comments, to put them in the chat. Watch the chat for our donation link. We also have opened up the closed caption. So there's an icon at the bottom of your Zoom screen that says live transcript with the little CC sign for closed captioning. And if you click the arrow next to that, then you can enable that on your computer screen. I mentioned to look for the donation link in our chat. Uh, Everything, every donation you make really does help us move universal healthcare forward to reach out to everyone. We have set a goal of $500 to raise during this program tonight. So keep watching for that link. Even small amounts, if you are able, do make a difference, and you can make a donation at any time. Let me start with a land acknowledgement. I'm here on Zoom, but I'm participating from the lands of the Coast Salish peoples. Please take a minute to acknowledge the peoples in the land where you are joining us from today. We acknowledge all of the ancestral homelands and traditional territories of the indigenous peoples who have been here since time immemorial. Our efforts to achieve healthcare for all include universal healthcare coverage for Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Puyallup, Suquamish, Tulalip, and Muckleshoot nations. As an organization, Healthcare for All has supported bills to control the cost of insulin and all prescription drugs. We've been involved for several years. We've been a part of helping coalitions to create the Total Cost of Insulin Work Group, the Prescription Drug Affordability Board, state efforts to actually manufacture or purchase or at least distribute and possibly distribute insulin and prescription drugs. And tonight, one of the leaders in our state, Kevin Wren, will be talking with us and will leading this discussion. He's a patient advocate with Washington Insulin for All. He's been on the front lines of grassroots efforts, so he's right in front of us, someone that we can follow, that's setting a role for all of us. He works both on the state and federal level, and it's just exciting to see that government and large corporations and even pharmaceutical companies are waking up that there's something wrong with this cost of insulin and all prescription drugs. Kevin studied public policy and health economics while he was in graduate school at UW, earning his MPA, and he's been involved for quite a while, and it's like an honor to be sharing the screen with Kevin, and we'll spend the next half an hour or so uh, of learning about how we can increase uh, access to insulin. So, Kevin, if you can unmute yourself, I will highlight you.
Thank you, Ronnie. And that's the honor's all mine. Your organization is great and has been doing such great work and supporting us for sure. So I know you guys get it, which is great. But I will share my screen and start my presentation. Okay, so I think I'll start off by just kind of talking about what diabetes is. I've been a type 1 diabetic for over 20 years now. My grandma, she was diagnosed when she was 19 and lived for over 50 years with the disease. The price of insulin in her lifetime went relatively unchanged despite us moving from those old forms of insulin to the analogs developed in 1996. My dad was diagnosed just a couple of years before me with type 1 diabetes, and my older brother was diagnosed about 5 years ago. So it runs rampant in my family, as it does with many type 1 diabetics, but also type 2 diabetes is an epidemic in this country, and it has been a priority for our state. Since I think 2014 is when they put out the first diabetes epidemic action report, just about the increasing crisis and how it affects people day to day. From drug affordability to access to food insecurity, all those things. So it's been really a poster child. Insulin has, and type 1 diabetes and diabetes for about 6 years. And we'll go into kind of why it is the poster child and why we talk about it so often. But I think I should really start with the Insulin for All movement and how I got involved in it. They switched my prescription at the counter, and my prescription went from, a $20 copay to over $1,000 because it wasn't covered by my insurance. It was like a Friday afternoon, so I couldn't go in to see my primary care provider. So I had to go to the ER to get a prescription for insulin. And this story isn't new for me, and it's not new for other people. I mean, the most vulnerable of us, those without insurance, face the highest list prices for insulin. And it's important to know that for all we've talked about insulin, its price has gone unchanged in the past 30 years. It's only gone up and gone up and up and up. But I joined the movement back in 2019. Insulin for All was getting off the ground, and there had been a chapter in Indiana and in the Midwest, but then I found a chapter here in 2019, and then started talking with legislators at the federal and the state level. But this graph really shows you kind of the increase in the price of insulin. It's really hard to kind of know what other items there that it's compared to, but on that list are pharmaceuticals, housing, and then inflation as well. So you can see how insulin has outpaced all those in the last 35 years. So how did that happen? There are only 3 manufacturers of insulin. So it's kind of a monopoly. They protect their patent on insulin, which they got almost 100 years ago for $1. The price again went relatively unchanged from 1922 when it was developed until 1996 when they developed analogs insulins. And those were a lot more stable, shelf stable, and they also acted quicker, and they also lasted long, or they lasted longer. So it's a lot easier to control your diabetes with these new analog insulins because they act quicker and they can cover you for a longer period of time, which makes the disease a little bit easier to manage. And I think they knew that they had this kind of game-changing drug, and since they came out with it, have been steadily increasing the price every single year, a little bit, just a little bit, lockstep with the other 2 manufacturers. So these 3 manufacturers have increased the price almost 1,200% over the last 30 years. That's a compounding annual growth rate of like 9%, which is scary high, especially for a drug that we need almost constantly. So they've kind of found a way to rig the system. And we can see now how this is impacting the market for healthcare and the price of healthcare. I mean, it just drives premiums up when there's this drug that costs $5 to make, but then winds up costing $300 for people. Even if you pay $20, your insurers cover it, and they're paying more than they have to. So that is why that's where we're at. I think how we first addressed it was in 2020, in the 2020 legislative session. There had been a bill that passed in Colorado that limited the co-payments that patients had to pay at $35 for insulin. I mean, again, it can cost from anywhere from $20 to $300 if you don't have insurance. And a lot of people use more than one type of insulin, or everybody uses more than one vial a month. So they've really rigged the game on how much money that they're collecting. It's literally, they're collecting twice as much from the US as the rest of the world, despite the US only having 10% of the global diabetes population. So they're making hand over fist off of diabetes and insulin here in America. And one of the ways we wanted to first address insulin access was just how much each person pays at the counter. And this Colorado bill that limited co-payments at $35 was kind of the first step in our first foray. In 2019, I met with Nicole Macri, and we kind of talked about this, and she helped introduce this bill. And then I testified alongside Healthcare for All Washington, Cindy Laws, and Sherry for sure, talking about the cost of insulin and how scary it is to ration insulin and how much you're gambling with your life, how it can lead to death. It can lead to further complications. So this is really a preventative measure to allow people to live unburdened. It doesn't affect the overall price. Like, insurers are still going to cover that full $300 cost. So premiums are still going to rise, and they're still going to make all this money off of insulin. But we thought this was the best way to help people immediately, was just the cost that they pay at the counter and limiting that. We got that passed almost unanimously through the House. I think we had one nay. And we had a number of legislators with diabetes or know someone with diabetes and truly understood the impact of insulin and the cost of it and not being able to access it and what that means. So we were able to kind of cultivate those relationships and set those up. And so we could come back to them in the next year to talk about some other bills. And something I'll talk about a little bit later is kind of our game plan for 2021. So we were really looking to lower the copay cap limit from $100 down to $35 in 2021. We thought $100 was still too much for people to pay. But then California, out of nowhere, passed this bill that allowed the state to manufacture and distribute generic drugs and biosimilar insulin. Just because of the cost, just to look at cost, and very similar to kind of what we looked at with the Prescription Drug Affordability Board that we passed this year. It's just what are the most expensive drugs and how can we lower the cost? Well, allow the state to create a competitor within the industry, because right now there is no competition for insulin. Again, they have increased the price over and over again, despite the formula really not changing. So in 2021, we introduced this bill that would allow Washington to distribute and manufacture biosimilar insulin and drugs. This won't go in effect for a number of years, but it's a big transformative step and different than what we did last year or the year prior. This really looks to help all the most expensive drugs and really work in tandem with the Prescription Drug Affordability Board to allow the state to directly enter the market. So this could have a huge impact if Washington can develop their own insulin. It's projected to cost only $200 to supply someone with insulin for a year if it's made by the state. So, I mean, if it costs $300 for one vial now, it can cost $200 for, 3 vials a month for an entire year if the state is able to manufacture. So you see how that can impact the market for diabetes and insulin access overall. And we really drilled down on this a couple weeks ago with legislators from California and Maine who passed similar measures and doing multi-state compacts. So have a, California and Washington branded insulin or something like that, and being able to offer that to other states that have not passed this kind of measure. So if Oregon wanted to buy Washington state insulin, that we would work with them, their government, to provide that at a low cost or at least competitive rate, so that people are not paying $300 for a vial of insulin because they shouldn't have to. And this also goes into like the thing we passed and why I think it resonated with lawmakers. We're in the thick of COVID, and like PPP materials were running out, and we were running low on like certain things. So this will allow the state to potentially, create a vaccine or to produce equipment for protecting frontline workers. Like there's a lot of things that this bill could do, and it gives a lot of authority to the healthcare authority to make those decisions, which I thought was unique and is different than California or Maine. So we're tackling, prescription drug in a very different way year after year. And you kind of see this in the next year, in 2022, what we did this last year with the state. We did a lot. We lowered that copay cap limit from $100 down to $35. That's a huge win, and it's really in line with what other states are doing, and it's actually affordable. Like $100 is not affordable if you have to buy 2 insulins and you have to like buy a lot of them. So lowering that to 35 was a big win. And then reauthorizing the total cost of insulin work group, which we established back in 2019, that didn't really get off the ground. I got chosen to represent patients as a patient advocate with this group. I think this will really illuminate why the formularies act the way they do and why insulin is so expensive. And I think it'll provide other pathways for us to provide insulin access beyond, this copay cap limit, which is one of the things that we added on. In addition to expanding the group to include more patients, because we want patient voices to be front and center. When we've talked about prescription drug affordability in the past, it's, primarily dominated by providers and people within the industry. And there's a lack of a patient perspective, which is really something at the heart of our Insulin for All movement, because patient voices are not often listened to. And we represent, I think, the group that needs to be paid attention to the most, because often this system discriminates based on race, ethnicity, religion, all the things. So it's important that we put patient voices first. And then part of that to really focus on patients was to cover the uninsured. This was a big one last year that we really had to fight for. But in Minnesota, they passed a similar copay cap limit that we did, but they also included this Alex Smith Emergency Insulin Act, which we replicated. Alex Smith died from rationing a number of years ago. I've advocated alongside his mom in Indianapolis. She's a great advocate, but the bill is named after him, and it would cover the uninsured. It basically allows for a free 30-day supply of insulin, regardless of your insurance status, provided by the state. And it was used over 1,000 times last year by Minnesota. So, I mean, when we're looking at the most vulnerable of us, we're trying to mitigate the ways in which they get insulin and find ways that access can really be applied to everyone, and not just, people with insurance or, with employment. And then one of the other big pieces that we helped last year was with the Prescription Drug Affordability Board. Insulin is kind of the poster child for prescription drug affordability, but it's not in a vacuum. Like I have numerous complications because of my diabetes, and I use a number of drugs that are expensive and shouldn't be. Lisinopril, which we all use for high blood pressure. That drug should not be expensive, and it should be available to everybody. And really looking at the system as a whole and not just how we can impact the access to insulin, but how that connects to broader issues of prescription drug affordability and like what other drugs can impact diabetes, not just type 1 diabetes, but type 2. I mean, there's drugs hitting the market now by Eli Lilly that will indelibly impact type 2 diabetes and how people manage that. So, finding a way to make that as accessible as possible in the shortest amount of time as possible was our goal. And so passing this was huge because, we don't just use insulin, we also use supplies and we use other drugs and we have morbidities and comorbidities and all these other things. So this last year was really about looking where we can support other organizations and becoming part of the Patient Coalition of Washington, which was huge. And I'll kind of talk about that a little bit later. But now to look at federal legislation, this is where everything will be solved. I'm a big advocate for states' rights, and I think states are laboratories of democracy and we can do a lot of good there, but I think we can help the most people at this federal level. But it is a harder game. We saw insulin being talked about with HB3 a number of years ago that I've spoken to reporters about, and just allowing the government to negotiate drug prices and this kind of simple idea, and then just seeing it go through different iterations. In Build Back Better, they tried to shoehorn it in and it died, unfortunately. But specifically looking at insulin, and now we have this Affordable Insulin Now Act, which it passed the House and it's in the Senate right now. It's introduced by Senator Warnock of Atlanta, or of Georgia. And I've actually had the pleasure of speaking with him and Senator Murray about this bill. It's a copay cap limit. Again, it doesn't apply to everybody, just those with insurance, especially Medicaid and Medicare. It allows the HHS secretary to negotiate drug prices, which is like a huge win and hasn't happened in a lot of years, which is big and huge. But again, it doesn't apply to everybody. So I've been speaking with Senator Murray to have her include the uninsured and really establish a federal price cap. Again, this bill wouldn't hurt manufacturers. They're still going to be making, $300, whatever per vial. It would just limit the amount that consumers would have to pay and would make insulin a lot more accessible. There's certain things built into the Insulin Now Act that look to penalize manufacturers for price increases, but those benchmarks are back in 2006, and that's already after the price had increased, tenfold. So there are a lot of limitations with the federal policy and how it holds manufacturers accountable and how much it allows patients to access insulin. But again, there's a lot of ways that you can tackle insulin access, and we're primarily focused on patient access. Like there's a lot of ways that we can go about it, but prioritizing that and like kind of triaging the different policy options that we can approach and trying to look at an incremental approach of how we can like slowly gain footholds and build momentum. It's really at the state level and what we can do at the state, and then having them kind of use that as precedent at the national level or with other states and partner that way. How, what do you do now? How do you act? So this is hard because there's so many things you could do. As I'm sure you're aware, you can do a letter writing campaign. You can do a lot of different things. But asking supporters to write letters is like a huge thing, and it's really it's old school, but it's super effective. Having a handwritten letter, I don't know how many times I've gotten back a handwritten note, but it's every single time I write a letter, I'll get something back. And just from my experience working with Senator Murray in her office, like there's always somebody that's going to be answering the phone and answering a call and looking out for issues, facing advocates like us. And so they want to highlight these stories and they want to hear from us. So I think letter writing is like, again, kind of a great old school method and one that works. And then every year, I guess since I moved back in 2019, we've held a demonstration uh, down in South Lake Union here in Seattle, right out in front of Novo Nordisk, which is one of the insulin manufacturers, protesting the exorbitant price of insulin. It gives us a great opportunity to meet each other because, amid COVID times, it's been really, really hard to meet socially and create those connections. So it allows us like some social distancing space to like get to know each other as advocates, which is great. And it allows us to get out our message. And then we've been highlighted by a number of local legislators. So Representative Jayapal, she's always retweeting and redoing our stuff, especially around our insulin protest. Jonathan Van Ness of Getting Curious with Jonathan Van Ness and Queer Eye for the Straight Guy, or Queer Eye. He's also been instrumental in kind of sharing our stuff, and he interviewed our organization's founders. So, finding those connections with people and like influential people and having them share stuff is really important, especially because a big portion of our movement lives online. And then I think another big part of it is media and online advocating. So our movement lives online. So we have an Instagram person and a Twitter person and a Facebook person, and we're always trying to engage with people online and through social media, pitching stories, pitching op-eds. I think this last year I got a letter published in the Spokesman Review about the Affordable Insulin Now Act and encouraging people to reach out to their senators in support of this. The year before, on World Diabetes Day, I had a letter published in the Tacoma News Tribune telling people about our organization and the demonstration we were holding down in South Lake Union. And then I've been interviewed by the Seattle Times a few times just talking about diabetes and access to insulin. I mean, our personal stories are so impactful, and being able to connect some kind of big issue like insulin and drug affordability to your personal story, it goes a long way in helping people understand why healthcare is right and why, my illness should not be for profit and why my livelihood shouldn't be exploited and extorted. But yeah, that's a big piece of it. And then kind of doing an ongoing assessment of where you're at and kind of your wins and your priorities. So every year we kind of do this. We see what is being done around the country in different states, like in California and the state manufacturing bill, to what are our priorities as an overall organization? Are we going to go after patent law and try to like change the patents around insulin? Or are we going to try to affect how drugs are marketed, because they spend a lot on marketing, but not a lot on research and development, which sucks. Or are we going to go after and try to shame the organizations themselves, like because they've been increasing these prices for so long and their CEOs make millions upon millions, and they're still pointing the finger at the US healthcare system while still making it extremely complicated and donating thousands to elected officials. So there's so much space we could cover, but it's really finding about where will we make the most impact and where do our stories resonate. And then I think this is kind of an ongoing thing, is collaboration and figuring out where are those touch points, because organizations like Healthcare for All Washington, like we have such aligned goals, and I feel like we're fighting for the same things. So, where are those spots where we can support each other, and who does the outreach? Are we going to be the first to make the step and try to build that relationship, or are we going to let people come to us? And I think we've always had the approach of being proactive and reaching out to people and trying to start that conversation. And I think it's worked well for us. Again, I think the Patient Coalition of Washington and things like that, where it's a band of similar-minded organizations connecting with a diverse array of stakeholders is really important. And we're seeing how impactful that can be. A lot of the bills that we talked about with Patient Coalition of Washington were passed because of our individual efforts as organizations in coming together and supporting each other. So collaboration, I mean, you'll go so much farther and I don't know. And you'll see a lot more blind spots too. I think it's also very hard from an organization that doesn't take any pharma money, because we make that a principled stance for Insulin for All. I think part of the problem that we've seen with the cost of insulin is that the organizations we rely upon for advocacy within the diabetes space have been relatively inactive. So the Juvenile Diabetes Research Foundation, although they've raised millions upon millions for diabetes research, we still don't have a cure. And those research dollars have really gone towards technology improvements. So things like continuous glucose monitors and insulin pumps, which are disproportionately unavailable to people of color and those BIPOC communities. So it's also very hard within collaboration, because we have these standards for ourselves that we don't want to take pharma money, but then like our strongest potential allies take that money and have been inactive. So we really had to forge our own path and create relationships where, it might have been easier to go with them, but we would sacrifice, our mission if we take this money and we become complicit in kind of these schemes that pharmaceutical manufacturers implement. And then I think kind of the hardest piece is evaluating your advocacy. There's a lot of ways we do this, but we do surveys and check in with advocates, do a little needs assessment, kind of always checking in within the leadership and within those that are advocating alongside of us, just to get a pulse on what's important, because the best ideas come from a diverse group of people. So trying to encourage, even if people don't have policy experience, what is an idea that we could use and potentially bring to a legislator to implement? So we're constantly trying to evaluate how we're doing things and then adjust if need be. But a mix of things for sure. And then kind of always remembering that anybody can be an advocate. You just have to practice. So it's just kind of making that time commitment and that kind of personal commitment, and figuring out, how much you can give, because I think we all know that you can get burned out from advocating, especially, screaming into the void of healthcare policy. Sometimes you don't feel heard, or you go a long time without being heard, but to just kind of keep at it and keep an eye on your mental health, because I think it's something that I've learned in the last year is just how personal draining this can be if you don't make time for yourself and you don't set aside this as your advocating time, and letting it bleed into your personal life. But always trying to encourage people to advocate and to stand up for themselves and to pass the mic when you need to. Yeah,
And and thanks for giving us that kind of nudge to collaborate, to advocate together. Certainly, Insulin for All, and you posted the email address and the website that you could look at for the Washington Insulin for All. I think your message about collaborating is so important. The Patient Coalition of Washington is an important voice, and organizations like ours have joined, and patient coalition groups have joined in Healthcare as a Human Right, another great advocacy group that is working with labor as well as with businesses and institutions that are kind of pushing up the price of all healthcare. So it's great to be looking at that. And we do have some questions. You've presented some great data. Thanks so much for emphasizing the importance of collaborating and setting examples of certainly one of the issues that each of us have in talking to legislators is, taking money from pharmaceutical manufacturers or large corporations that are making things harder for people. So I think that's that example of not taking money from those groups is it's just a great point to for all of us to keep in mind. So if you can take a few minute break here, Kevin, while we put some questions together, and we're going to have a. I'm going to ask Peter Lucas from our board of directors, the treasurer of Healthcare for All Washington, to step in to talk a little bit about making a donation, how easy it is, and Peter is a practicing psychiatrist, so he's still on the front end of. I'm trying to bring you up, Peter. Add spotlight. There you are, uh, and and has been leading a lot of our efforts. We have been putting the donate link in our website, but Peter, can you tell us a little bit about how easy it is to donate?
Well, certainly, and I'll tell you why you should donate. And first, I want to thank Kevin for your excellent presentation. And it highlights the need for major changes in a critical component of our dysfunctional healthcare system, namely pharmaceutical affordability. But there are many other aspects of that system in dire need of an overhaul. And we at Healthcare for All believe that the creation of a universal single payer healthcare system in our state is the best way to effect that overhaul. And we are working diligently towards that end. But in the meantime, on that journey, there's much we can and have accomplished. We worked closely with the legislature this past session to pass 22 bills that improved Washington residents' health care. We were a driving force behind the Universal Healthcare Work Group and had 7 of our members in that group. And their work in turn led to the creation of the Universal Healthcare Commission, also with many members we advocated for, that is tasked with creating a system to provide healthcare to all Washington residents. And that group could craft a single payer system based on our bill, the Washington Health Security Trust. But in order to maintain our momentum, it is vitally important that we grow our membership, educate the public, and mobilize our supporters to spread the word to their family, friends, and most importantly, their legislators, as Kevin was highlighting. We can achieve these goals through social media, monthly webinars, meetings with civic groups, and by hosting other events. And our work requires dedicated lobbyists, and we also have a communications specialist on staff, and there are other fixed costs needed to keep us running. These activities and obligations all require funds, which is why we are asking you to donate tonight. We were encouraged by the support we received through the recent Give Big campaign, but we could really benefit from additional funds. So as Ronnie said earlier, our goal tonight is $500, and you can go to our website and click on the donate button, or even easier, just go into the chat and click on the prompts there, and they'll take you right to our donate page. You can make a one-time donation, but we would especially appreciate it if you can make a monthly recurring donation. It's like a Netflix subscription, except you might get universal healthcare instead of cheesy movies. So please donate so we can spread the word and bring about universal single payer healthcare in Washington. That's it.
Thank you.
Made my pitch.
Thank you, Peter. And please, as Peter suggested, go into the website or into the chat, and you can find that link. And you can also, we'd appreciate it if you can also identify yourself. Take a minute to add a question for this upcoming, we're going to have a Q&A session in a minute or so. If you can add a question add your questions to the chat, and identify yourself. If you're have an abbreviated name, especially on our website or on your Zoom link, let us know who you are, where you're from, and what your main interest is. So go into the chat, look for that link, identify yourself, added your questions and answers. And I think I'll bring Kevin back up here, and also would like to introduce Cello Echeverria, a volunteer with Healthcare for All, who will, as soon as I can bring her up, I'm not working here. Spotlight. Cello is just a hardworking volunteer here who has been putting your questions and comments together. And why don't I let you and Kevin go through those questions now?
Kevin, thank you so much. This work is so important. And to highlight the importance of this, I would really like to ask Sherry Barrett to speak in her own words. She has an insulin story that she wrote in the chat, and I think it's important that she speak it herself, if you wouldn't mind, Sherry. Can you unmute yourself?
Hi,
Maybe
I'm
not.
Sherry. Here, I'll put on a video. Now as my dog joins me. I'm a retired physician. I had to retire early due to orthopedic problems, and the inability to walk contributed to me developing diabetes, which became insulin dependent about 5 years ago. And I had some shocks going to the pharmacy before that. I remember once I had pneumonia and I had to pay $300. But since I got on insulin, the shocks have been quite regular. And that's where I'm really happy, because now insulin is now steady, but I'm paying $1 per needle, or 80 cents per test strip. So I've had to stop testing so often. And I tell myself, at least I'm stable, but I used to manage a lot of diabetes, and not every diabetic is stable. And so it worries me a lot. And I've also become afraid to spend any money on anything, because I have to have a good amount of money in the bank at all times in order to cover what's coming up. So I was put on Trulicity about 3 years ago, and Trulicity has actually made my life much better. My hemoglobin A1C is now 5.8 or 5.9,
Please.
and I can get away with eating a few more carbs, although I still try to be careful with my diet.
That's good. That's good.
Yeah,
I
but
mean, I totally hear you. That's one of the things we're actually looking at this year is how can we impact the cost of supplies? Because, without supplies, your insulin is useless. And if you can't check your blood sugar, you're not able to correct appropriately, and you're not managing as best you can. So I think that falls under the guise of kind of insulin for all. It's also supplies, and it's access to the technologies. It's access to like needles and test strips and things like that. So that's something that we're looking at to affect the price of now this coming legislative session, because it's so big. Because and although we do have these copay cap limits on the state plans, it only applies to roughly 1 in 4, which is not great. So we're trying to figure out ways that, again, we can work at the federal level to allow Medicaid and Medicare to negotiate insulin prices, and then potentially put limits on how much someone spends out of pocket total for their Medicaid or Medicare. And then getting down to that supplies piece, because I mean, if you're rationing insulin, you're rationing your supplies. If you're rationing your supplies, you're not managing your diabetes as best you can. So we're really looking at that this year, because I mean, as you said, it's so important. If you don't know what your blood sugar is, you're not managing as best you can.
mhm. Yeah, I don't know why my Trulicity went from $40 to $240, and that was another shock.
Yeah,
But
it's,
from what I understand, Medicare is set up now so it changes. They have different tiers, and the pharmacy can't explain it. It's so complicated. The pharmacist can't figure it out. But I
Yeah.
know at the end of every year, my prices go way down. They
Yeah.
start out reasonable and then they go way up. And
yeah,
I
it's a
don't know what
black
they'll do
box.
this
And
summer.
yeah, it's something that we're looking at with the total cost of insulin work group, just to understand why these drugs fluctuate so much and why they have to change and why the formulary is such a black box and such a mystery.
Linda actually has a question. Sherry, I'm sorry to cut you, but we do have other questions, if you don't mind.
It's fine.
Okay, in terms of the cost of insulin only being covered for state copay caps, Linda asks whether this applies to patients with employment-based insurance, as well as Medicare isn't regulated by the state, and Medicare Advantage C covers prescriptions without Part D. Does this mean that Medicare patients don't have access to the copay ceilings? So 2 questions. First of all, employment-based insurance, and second of all, Medicare and copay ceilings.
Yeah, again, this only applies to really 1 in 4 people in the state with insurance. Those copay cap limits, they don't apply to federal plans like Medicaid and Medicare. Medicaid, I think the copay limit's like, I think their limit is like 0 or something, or dependent on how much. But again, the Affordable Insulin Now Act that is proposed will allow the HHS secretary to negotiate for Medicare. And so potentially we're hoping, I mean, this is the other piece of it that's really hard, is that it's always an election issue. I usually get calls from a legislator sometime in October wanting to tout our stories about insulin access. And while we recognize that we're poster children for drug affordability, it's also, we want to hold them accountable, and we shouldn't be exploited for, because we're being exploited. So really trying to talk to legislators now and make sure that this is not just like gonna come with the election, that it's gonna be something that they promise they're gonna resolve and that they're gonna work on, because yeah, it shouldn't be a burden to manage a chronic illness, and they shouldn't be able to make themselves rich off of our disease. Again, right now, the copay cap limits that are proposed within the Senate would only apply to about 1 in 4 people with state-based or federal-based plans. So there's a lot of negotiations with Medicaid and Medicare. Again, a lot of it's still up in the air, but what they're trying to do is implement essentially what we have already in our state. So a $35 limit for any kind of federal plan. I think they're still working out the language on that, and we're trying to get them to implement a federal price cap so that every single person, regardless of your insurance status, will be able to access insulin at $35. But yeah, it's
Right.
complicated.
So Ronnie actually has a question about the drugs themselves, and he asked, are there any generic or biosimilar alternatives for the expensive analog insulins?
Not really. I mean, Basaglar, nothing has really entered the market that has lowered the price. So even though there are biosimilars available, they haven't shown to decrease the overall price or be offered in any kind of meaningful way. So yeah, it's hard. But I mean, also again, like these biosimilars don't act the same. We had someone in our Insulin for All group, we spoke just last week, and she had tried this new long-lasting version and it just didn't work with her. And it's like, what is your alternative if the biosimilar doesn't work? So these things aren't one for one. And it's actually been kind of hard talking to legislators about this. I spoke with Senator Rand's people about the Affordable Insulin Now Act and really had to demystify a lot about insulin and access to insulin and diabetes itself. And that, these biosimilar drugs don't work the same for every single person, and they don't work the same as the branded drugs. They haven't lowered the price of insulin and continues to climb. So yeah, thank you for that question.
And Paul, would you like to ask the question that you had asked in the beginning before we went live, or would you like to ask the insulin for all, healthcare for all right question? I want to make sure they're both covered.
Well, I just was wondering, about Kevin, about joining the Healthcare is a Human Right Washington coalition of organizations. I don't know if you would get much benefit because we're already advocating for the insulin price control bills and so on, but you could be, a part of that and providing input.
Yeah, that's really something that we look at. I think it's hard for we're, I think, nimble as a state-based organization. We can get a lot done and choose who we partner with. And then getting official approval from our national organization and the international organization, because T1 International is based out of London, and there's a district office in Washington, D.C. that we have to communicate with. So there's levels there. But they give us a lot of free reign to join things like Healthcare for All Washington, Whole Washington, and the Patient Coalition and things like that. It's just where our missions kind of align, and whether or not, the organization's pharma backed. But yeah, we'd definitely be interested in joining Whole Washington.
I think that covers the questions that I have, at least if there's not anybody else. And just to clarify, it wasn't Whole Washington, it's Healthcare is a Human Right,
Healthcare is human right.
which Whole Washington is also a part of, I believe.
Yeah, and I think, Kevin, that you have played a valuable role in healthcare is a human right, and you've sent Maddie to the front line to join in. So, Paul, I think the answer to your question is, like Kevin said, that it is important to collaborate with other groups, and so I think they're there. So, Cello, Consuelo, thank you for helping pull those questions together. And Kevin, it really has been good to have your voice as a part of our program tonight, as a part of everything that we're doing here. So thank you. Thank you.
Thank you. Your organization's amazing, and you do a lot of great work. And I always love seeing Healthcare for All Washington at these testimony hearings. So keep it up.
All right. Thank you.
Thank you.
And thank you all for joining us tonight. Thanks to our volunteers, to Peter and Rich, who is behind the scenes, letting people in and answering little odds and ends questions. Thanks to Cello or Consuelo for leading that Q&A, and to everyone, to our communications team for making sure we promoted this to everyone and got the information out. Thanks to DW, who's also in the background. Thank you to each of you for joining us tonight. And we will be skipping July, figuring people need to take vacations now that the pandemic is totally over and there's no more COVID in our lives. Well, people need a little break in life anyway, but we will be back in August doing these second Wednesdays, so join us for that upcoming program. Thank you all very much.